of with really as hyperthyroidism. This really is going to cover different causes of hyperthyroidism, as well as pheochromocytoma, multiple endocrine neoplasia, a number of other pathologies, the treatment of it, the understanding of how the pathology works. So let's get started. I think the first point that I'd like to make is that there is a significant difference and a specific set of features that you get with hyperthyroidism and Graves' disease, and people often mix up these two things together. And the starting point probably is to describe that the thyroid hormone itself is there to set your adrenergic tone. So kind of your baseline level of alertness. If you have too much thyroid hormone, then your body temperature is hot. You are cold intolerant, which is you wear clothes that are cooler than the environment would suggest. And you have a fast heart rate. You feel agitated and restless. That is hyperthyroidism. And I put them in categories of head, heart, and hot. And this gives me a bit of an idea when we get to the stage of deciding whether somebody needs to come into hospital for the treatment of their hyperthyroidism or whether they could be treated in the community. So, if you are just hyperthyroid and you have features of hyperthyroidism, we call that as being thyrotoxic. If you get to the stage where that hyperthyroidism is so significant you are in imminent danger, we call that a thyroid crisis or a thyroid storm. If you have any features that suggest you may have a thyroid crisis over here, if you have any one of these features, then you need to come into hospital for treatment. If you have all of these features and none of these features, then at that stage you can be treated in the community. So what I mean by head, that's a kind of level of agitation, feeling agitated. Heart, you can have atrial fibrillation. You don't need to come into hospital. You can also be tachycardic, and that can be with a heart rate of greater than 100. That's the definition of tachycardia. And when it comes to heart, when you come to hotness, this is about having heat intolerance. And heat intolerance, as we said, that's not liking being in a warm environment. It's slightly different then when you get to the stage where you have a temperature greater than 38 degrees Celsius. Once your thyroid level has got to that stage that you are running a temperature, you need to come into hospital. That is termed then a thyroid crisis or a thyroid storm. When it comes to your heart, you can have atrial fibrillation and a tachycardia, but if you show any features of cardiac failure, swelling of your ankles, pulmonary edema, high JVP, engorged venous tone, that's the stage that you need to come into hospital. And head, agitated, as soon as you move across to then having seizures, whether those are partial but usually generalized tonic-clonic, at that stage you need to be admitted to a hospital. So those are your features of thyrotoxicosis. And then you have a thyroid crisis and a storm, and then you need to come into hospital. I'll move my head there so you can see 38 degrees. When we are deciding what somebody's thyroid state is clinically, somebody can be hyperthyroid from a serological test, that is having very low TSH. That's your body trying to turn down the level of thyroid hormone, and then your T4 and T3 being elevated, that is now hyperthyroid. But you then, when you become clinically symptomatic, that's when you are thyrotoxic. If you are hyperthyroid, but you have no clinical features, we just call it hyperthyroidism. Euthyroidism is when you are clinically examined and you have no features of hyperthyroidism. Although there are a number of features or there are a number of causes of hyperthyroidism, the most common of which is Graves'. It's important to understand that Graves' has some specific features that you don't find in any other causes of hyperthyroidism. Those features include pretibial myxedema, pretibial myxedema, clinically, when you look at the shins, it looks like a slightly old dehydrated orange. It's an undulated surface, slight kind of puckering of the skin, but it isn't true edema. True edema, when you press on it, leaves pitting marks. I mean, personally, I wouldn't have called this myxodema because it really isn't anything to do with edema. And this is the reason that you have to call real edema pitting edema, because of some idiot caused this pretibial at some point, pretibial myxedema. So they've kind of tarnished the use of the word edema. The next is thyroid acropatchy. And that looks like clubbing. But the difference between thyroid acropatchy and true clubbing is when you look at the fingers, you would swear looking at the fingers they had clubbing. But then when you then press them together, you would still be able to see a star of light. That is called thyroid acropatchy. And finally, the last one is exophthalmos. Now, exophthalmos is eyeballs sticking out of the head. The eyeballs have been pushed forward, and when you look on from the side, the eyeballs are physically sticking forward in the head. Now, please don't mix this up with lid lag. So right now, if I get really angry and I start screaming at some poor SHO, my eyelids are being pulled back, and the protuberance of the eye is an illusion because the position of my eyeball in my skull hasn't changed. It's just the position of my eyelids. So that at the moment, as I'm getting more and more angry, is lid retraction, pulling back of the lids. Lid retraction is also accompanied, if it's been there for a fair period of time, with lid lag. And what I mean by lid lag is you get somebody to look up, and if I look down very quickly, my eyelids drop down, so the tops of my eyes aren't seen. Whereas with the lid lag, the eyelids are being pulled back, and as I look down, the eyes are still open, and then the eyelids fall. So that's called lid lag. This is mainly due to the fact that there are two muscles that innervate the eyelid. One of them is called the levator palpebris superioris. That's the one that when I want to open and close my eyes, I can. And then there is another muscle called the Muller's muscle. And the Muller's muscle, so we've got levator palpebris superioris, and we've also got Muller's muscle. This is voluntary control. This over here, Muller's muscle, is sympathetically innervated. So that's the one as my sympathetic tone goes up and up and up. My eyelids get pulled back. The same way as the more angry I get, the more sympathetic tone I've got because the more adrenaline there is around, my eyelids pull back. And in hyperthyroidism, you get increased levels of sympathetic tone, which then pulls that eyelid back. So all of those on this side are features of any cause of hyperthyroidism. But if you get one of these features is due to Graves' disease only. So if you examine somebody, they've got palpitations, in atrial fibrillation, agitated, as well as having heat intolerance, and combined with that, they have exophthalmos. The only cause could be Graves' disease. On to a couple of little important things for exam when it comes to exophthalmos. Again, that's only caused by Graves' disease. Don't use the word exophthalmos to describe eyeballs sticking forward, unless it is eyelids sticking forwards in Graves' disease. So if you were to have lymphoma pushing your eyeballs forward, you can't call that exophthalmos. So the first part about it, it is only caused by Graves' disease. Secondarily, it can be unilateral. So that can be only affecting one eye. Strongly associated with Graves' disease when you also combine it with smoking. So there'll be something in the question about smoking. The biggest impact that you can have to regression, or at least stopping this from progressing forward, is smoking, is by stopping smoking. Only thing that you can really do to treat it is surgery. Under desperate circumstances, people have used radiotherapy in the past. So we are now have an idea of what euthyroid is, somebody who looks normal, somebody who is thyrotoxic, that is somebody with symptoms, somebody with thyroid crisis, somebody with thyroid crisis has seizures, a temperature, signs of heart failure, then you're coming into hospital. We have an idea of that, exophthalmos only being associated with Graves' disease and only the features of Graves' disease. I'm going to talk about thyroid uptake scans now. Thyroid uptake scans are helpful to delineate what the underlying pathology is that's causing this. Graves' disease, we'll start off with what does that look like? In Graves' disease, you look at the uptake of the thyroid. That's not a thyroid. So I'm going to draw, this is going to be my thyroid gland. The thyroid gland is going to be globally hot so that the whole thing is turned on, metabolizing, making new thyroid hormone. So that's Graves' disease. We can have a thyroid scan where we only have a couple of areas of hotness. A couple of areas of hotness, as temptation is to say that if I have hot spots on the thyroid scan, that equals cancer. But that's not the case. We talked about in the course the fact that if you get a lump in a gland and that produces the hormone that that gland is supposed to produce, that's usually an adenoma, a benign adenoma. So in actual fact, with thyroid uptake scans, what I'd be more concerned about for cancer is that we've got an area of no activity. So the rest of the gland is normally active. We've got a cold spot. And in that case, if we have a cold spot, we should be doing fine needle aspiration. Now, fine needle aspiration is not the test that we do in lymphoma. Going back to lymphoma on the course, we had to do a true cut biopsy, apple core it, to look for those eggs that may have broken open and where have these lymphocytes gone. And then true cut or an entire lymph node biopsy. But for thyroid cancer, FNA is fine, and we usually use ultrasound scan to see that lump and then take a biopsy of that. So that is this over here, toxic multinodular goiter. Cold spot is more likely to be cancer. Next one is a gland that is cold. So there's no activity within the gland itself. You then start thinking, well, I've got lots of thyroid hormone coming around my body. I've got lots of thyroid hormone going around my body, but if the gland isn't making it, where is it coming from? And the analogy that I use for this is it's a little bit like a schoolyard bully. A bully grabs some poor nerd in the playground, grabs him by his ankle, starts shaking that nerd, and then all of his lunch money's falling out of his pockets. And then once all of the money's fallen out their pockets, the bully picks up the lunch money and then leaves the poor little nerd alone. And the same thing happens with viral infections. You can get viral infections and inflammation of the thyroid gland. And the thyroid gland is taking a beating at this stage, and it's dropping all of the stored thyroxine. But because it's being beaten up, there isn't any level of activity. So we'll go through stages. The first stage is going to be that the thyroid gland drops all of its stored thyroxine. That will carry on for a number of weeks to a small number of months, and eventually it will start running out of thyroxine. So you'll go through this phase of initially hyperthyroid, then you'll move into the hypothyroid, and that's the nerd's being shaken, all of the money's fallen out of his pockets, and he has no money left. So we go from hyperthyroid to hypothyroid. There is a number of names for this condition. It's a little bit like glomerulonephritidis that we talked about before. And the names for them include subacute thyroiditis, subacute, can also be called de Quervain's, veins thyroiditis, or post-viral thyroiditis. The management for this is essentially conservative. You leave these people alone. If they get to the stage where they are hypothyroid, only then you intervene. It's a little bit like the same of there's a nerd being beaten up on the playground. Most kids will leave them alone to their own business. But if that bully carries on beating him, even after all of the lunch money has fallen out and he's still shaking, at that point somebody's got to step in and say, you know, enough's enough. And at that stage, you treat the person with steroids. But whilst they are hyperthyroid, you just leave it well alone. So that's Graves' disease, toxic multinodular goiter, subacute thyroiditis, de Quervain's thyroiditis, and post-viral thyroiditis. Just at this point, another question that sometimes comes up is T4 is the test that we do on most people. It is a cheaper test. T4 is got a longer half-life, so it gives you a more reliable indication of what their thyroid state is over a period of time. It's kind of a little bit like the HbA1c of your thyroid gland. And then you have T3. Now T3 is the more active, but a shorter half-life. So although it's more active within your body, physiologically active, and has a shorter half-life, we tend to focus on this one because if T4 is okay, the likelihood is that T3 is okay as well. And in combination with the fact that TSH is a very good predictor of what your body's doing, we often don't need to go down and measure T3 levels. So TSH, if TSH levels are high, that's your brain screaming out, please make more thyroid hormone. If TSH level is low, that's your body saying, you've got too much thyroid hormone in your body, we need to turn the levels down. So TSH gives the best idea of what your thyroid state is. When you start moving into moving thyroid hormone levels, then you can get slightly more detailed levels. So we're now moving on to the treatment of hyperthyroidism, and that's the treatment of what's going on with the thyroid hormones itself. So, treatment number one, we can treat the symptoms of hyperthyroidism. Some of that's the agitation, so actually benzodiazepines work quite well for the agitation. We can use something to control the agitation from a different route, and that is by using propranolol. This is the treatment of hyperthyroidism. Propranolol is used specifically because it crosses the blood-brain barrier, and there aren't any other frequently used beta blockers that can cross the blood-brain barrier. So other more specific, especially cardioselective beta blockers, work on the heart, they work on peripheral beta receptors, but if you want something to get into your brain, so if you get performance anxiety, you can take propranolol. If you get panic attacks, then propranolol will work. In those circumstances, carvedilol won't work, atenolol won't work. It might control your heart rate, but you'll still be left with a central feeling of there's something catastrophically wrong and that internal feeling of agitation. So what's nice about this is it takes away the feeling of agitation, but it also slows down your heart rate and controls your atrial fibrillation if you've got it. Not particularly well, you need to take a TDS. It's not as good as the others, but it crosses the blood-brain barrier and works peripherally. The next treatment that we need to talk about is the control of thyroid hormone itself. And we have two drugs that we use, carbimazole and propylthiouracil, PTU. For exam purposes, see the P equals pregnancy. So that is the anti-thyroid medication that you use in pregnancy. Carbimazole is safe in pregnancy, but there was an untrue and unbased association with a condition called aplasia cutis. And if you open up a window in your browser and look up aplasia cutis, when a baby is born, without the skin on its scalp, this open area looking very raw, that is called aplasia cutis. And the thought was carbimazole caused aplasia cutis and propylthiouracil didn't. So in pregnancy, I'll move over here so it shifts me over. In pregnancy, the thought is if you take propylthiouracil instead of carbimazole, you won't end up with aplasia cutis. The reality is, though, it makes no difference. But for exams, P equals pregnancy. We can also use iodine. Now, that is paradoxical because if I were to take iodine, your brain thinks, well, isn't iodine used to make thyroxine? So your body would absorb the iodine would be taken up by your thyroid gland, and then you'll just make more and more thyroxine. So this is paradoxical. Why are we using iodine for this? Well, what is interesting is your body does have a protective mechanism, and it says if you were to eat a large amount of iodine in any one go, the thyroid gland has a safety switch, and that safety switch turns the thyroid gland off because there's too much iodine around. And I don't know whether you ever watched the series Chernobyl and saw that when the scientists realized that there had been a radioactive leak, they all started taking Lugol's iodine tablets. And the Lugol's iodine tablets was to do this, is to flood your thyroid with iodine, turning your thyroid off so that when you inhaled radioactive iodine isotopes, they didn't then stick in your thyroid gland and give you thyroid cancer. So iodine itself can be used to turn off your thyroid gland. You have to use this before you do this, just in case. Make sure you've taken some medication to turn your thyroid gland off, just in case when you give somebody iodine, they use some of it to make more thyroxine. And if you're right on the edge of becoming thyrotoxic, then initially you may get worse before you get better. You've probably never seen iodine on the ward. Most of these are found in radiology. We use iodine dyes in certain types of scans to make the clarity of the scan better. So if you have somebody in a thyroid storm, the process is essentially use all of these medications in as quick a succession as possible. The lighter your symptoms are, the more you can stop further at the top of that graph. So the more severe, thyroid storm, all of them. If somebody is just hyperthyroid, then you can use less of them. Next page. Associations of hyperthyroidism. That often comes up more as a part 1 question than part 2 questions. So these are associations. Graves' disease is an autoimmune condition. If you have one autoimmune condition, then it's fairly likely at some point you may develop another. So in Graves' disease, you are making anti-TSH receptor antibodies. These antibodies attach onto the TSH receptor and trigger complement activation And that antibody is beating up the receptor itself. So this is your receptor. You then get an antibody coming and attach it to it. We talked about complement activation, damage to the receptor. But just like using a hammer on a doorbell, if you hit a doorbell with a hammer, you are going to get some ding dong, ding dong, ding dong, ding dong, ding dong. Eventually, if you hit it for long enough, you'll break the doorbell and it will stop ringing. And the same thing happens in Graves' disease. You can be hyperthyroid in Graves when that antibody over here, this antibody up here, is attacking the receptor and you're still getting ringing of the doorbell. After a while, some of these receptors start to get so damaged they don't work anymore. And when they don't work, then you end up euthyroid, where some of them are being fired a lot and some of them are badly damaged. And after a long enough period of time, you may end up hypothyroid, where so many of those receptors are damaged, you now have low amounts of T4 and T3, and your TSH level starts to go up. So remember that when you see somebody with exophthalmos, pretibial myxedemia, and thyroid acropatchy, you can say this person has Graves' disease. The next step is you need to say whether they are hyperthyroid or thyrotoxic, whether they are euthyroid or whether they are looking hypothyroid. They've got lots of clothes on, they're quite slow, they put on weight. That's into the hypothyroid category. And then if they are up at the hyperthyroid, you then need to say, are there any features of a thyroid storm or a thyroid crisis? So the first associations of Graves' disease in hyperthyroid is all of the other different types of autoimmune conditions that you might get. Then the other association is hypokalemic, hypokalemic, that's low potassium, periodic paralysis. We're not going to talk too much about hypokalemic periodic paralysis. In part 2 questions, when it comes up, most of it is somebody's got a low potassium and episodically finds it difficult moving. It will be this case, and then they'll look for the fact that you know that there's an association with hyperthyroidism. Not specifically Graves, any forms of hyperthyroidism. Other things with is myasthenia gravis. Is associated with thyrotoxicosis. As far as myasthenia, be aware, firstly, that it's associated with hyperthyroidism. Also remember that there is association with a thymoma. And sometimes people with refractory myasthenia gravis end up needing to have their thyroid, the thymus gland, which is in the mediastinum, their thymus gland removed. Myasthenia, just while we're here, that is acetylcholine receptor antibodies. So anti-acetylcholine receptor antibodies. How are we going to treat it? If it's an autoimmune condition, we've all got we start off at the bottom of that triangle that we talked about. Steroids at the bottom, disease-modifying agents, MABs, and then desperation at the top. Steroids are often treated. Very occasionally you need disease-modifying agents. And then at the same time you use things that will block acetylcholine reuptake so you can flood the receptor with more acetylcholine. That's pyridostigmine. That's pretty much hyperthyroidism, but while we're on the thyroid gland, we need to quickly talk about thyroid cancers. For thyroid cancers, there is something specific to know about all of the different thyroid cancers. We'll run through them very fast. We have papillary. This is by far and away the most common thyroid cancer. going to miss follicular. There is nothing interesting about follicular thyroid cancer. No questions ever come up on it because there's nothing particularly notable. So F stands for follicular. M is medullary. Medullary thyroid cancer is associated with multiple endocrine neoplasia, and we're going to come back to that, type 2. Medullary thyroid cancer can also be monitored with calcitonin. Anaplastic. The question will have features of somebody has a lump on the side of their neck. It's usually an elderly patient. That grows very, very rapidly to the point where it starts blocking their airway, their voice changes, and they die quickly afterwards. Okay, we've got wanting to go over why we give propylthiouracil or carbimazole before iodine. We'll come back to that in just a second. So anaplastic is rapidly progressing. Fatal. There's no real treatments for it, and that's why you need to be able to identify that in questions. It's a clinical question, more commonly in part 2 than part 1, but it does come up in both. And then the final is lymphoma. This is the rarest. So we don't get too many. Which of the following is at least likely to be? But this was the which of these is least likely. You've got a lump growing into your, so that's rarest. Which of these is least likely, and lymphoma will be the question. So we wanted a bit of clarification on why we give carbimazole before we give iodine. So it's carbimazole first. So if I were to draw a graph, let's pretend this is the level your body is making thyroxine. If we give a huge meal of iodine here, there's a part in your brain that says, if iodine is used to make thyroxine, surely wouldn't the levels of thyroxine just skyrocket because I've given loads of iodine to this person? But in actual fact, there is a protective mechanism that kicks off, and instead your thyroid gland turns off. So your thyroxine level drops. And then it waits a period of time, and after it's waited and it thinks that you've processed that iodine, then it comes back up, your thyroid gland wakes up, and then it goes back to normal. So you've got this first part. This is what you would think would happen. You've got this bottom. This is theoretically what your thyroid gland would do, is turn off, wait a while, and then wake up. In reality, we get somewhere halfway between the two. We take an iodine meal. Initially, your body starts to produce more thyroxine. Then it says, oh, I can see what's going on. And then the level drops back down again. And then it wakes up. And as you can see, there's this short period where things get worse before they then get better. So the idea is, at an earlier stage over here, I give carbimazole or propylthiouracil. This turns off the thyroid, or this aims to turn off the thyroid gland, but it doesn't work 100%. It's not fully strong. It kind of turns down the thyroid gland a little bit. So you get some turning down of the thyroid gland. So we go back to here. The thyroid gland turns down a little bit. And even then, when you get a blip with iodine, you don't get as bad as you were before. And then it drops down and comes back up. So rather than just leaving it, if you had propylthiouracil on its own, you'll probably only get a little dip down. And then things will come up unless you kept on dosing propylthiouracil or carbimazole. But you may want to bear in mind, at the beginning stage, you are in a thyroid crisis. And I could have symptomatic thyroidism, hypothyroidism here. I could have a thyroid crisis or a thyroid storm up here, or maybe even up here. And just by taking that iodine, I get a push through into a thyroid storm before I get improvement. So if you could let me know whether that's fully clarified that for you so you understand, and I'll move on and look in the chat to see whether that's description has satisfied you. So those were thyroid cancers. We now know most common thyroid cancers, the ones that are associated with multiple endocrine neoplasia. We know that on a thyroid uptake scan, this would be a cold spot, not a hot spot. The investigation would be an ultrasound scan with fine needle aspiration. So we've gone through a whole process of linking these through to other subjects. Now we've brought up multiple endocrine neoplasia. I think we'll carry on and look at ways of remembering and the things that will come up in exams in order to try and confuse you. Okay, if you have got your book on you, if you turn to page 84, and on page 84 there will be a graph, a chart there showing multiple endocrine neoplasia type 1 and type 2. So we have type 1 over here and type 2 on the other side, multiple endocrine neoplasia. On type 1, it's all of the P's. I remember P gives me the clue for all of them. This is pituitary, actually I'm going to start with over here parathyroid at the top. Parathyroid. So this is hyperparathyroidism. High levels of parathyroid hormone giving you a high calcium and a low phosphate. We talked in the course again, pepper pot skull, subperiosteal thinning and tough resorption. And this is the parathyroid, and important to note, adenoma. In multiple endocrine neoplasia type 2, that's broken down into 2A and 2B. And in exams, what they like to confuse you with is you get your parathyroid, you get hyperparathyroidism, but that's caused by hyperplasia. That's hyperplasia by both of your parathyroid glands. So that is a classic exam question, tripping you up between type 1, multiple endocrine neoplasia, and type 2A. The fact that it's an adenoma in one and hyperplasia in the other. The next feature with multiple endocrine neoplasia type 1 is pituitary. I said they were all P's. This is a P. Pituitary is another P. And this is giving you a prolactinoma. Another P. Parathyroid, pituitary, prolactinoma. And then at the bottom here, pancreas. And that pancreas tumor would secrete a hormone that gave you peptic ulcerations. That's a gastrin secreting tumor. And in an exam, to make it clear as well, that is Zollinger-Ellison syndrome. Gastrin secretion giving you ulceration. And as soon as you see, we talked again in the course about the fact that if you had a blood test with creatinine normal, and then that creatinine level went high over a short period of time, insurance medical, and then being followed up later, that would be a code way of saying you have rapidly progressive glomerulonephritis. For Zollinger-Ellison syndrome, those are ulcers past D2. D2 is an area in your duodenum. And so they say in a part 2 question, an OGD is performed. We see gastric ulceration going all the way down past D2. They're wanting you to say that equals Zollinger-Ellison syndrome. And then most frequently that's associated with type 1 multiple endocrine neoplasia. Type 2 multiple endocrine neoplasia is broken down. It shares a couple of things in common. At the top, a couple of things at the bottom that it shares in common, but at the top you get difference of marfanoid appearance, and mucosal neuromas. We talked about conditions that gave you a marfanoid appearance. That was marfans with a upwards lens dislocation, homocystinuria with a downwards lens dislocation, and then we had a chart talking about homocystinuria, cystinosis, and cystinuria. So at this end, you've got marfanoid, mucosal appearance, medullary thyroid, cancers. So if you look at one end of this, we've got parathyroid, pituitary, pancreas, all P's. Right at the other end of this, we've got all M's, marfanoid, mucosal neuroma, and medullary thyroid cancers. I am going to move this. Into the middle and rub out him. So both of these, you can get medullary in type 2A and type 2B, medullary thyroid. And the other thing that it shares in common are pheochromocytomas. So MM and M, those are your three M's on the right-hand side, all P's on the left-hand side. Both men 2A and men 2B share in common medullary thyroid cancers and pheochromocytomas. So we talked on the last slide with medullary thyroid cancers, and for medullary thyroid cancers we said you could monitor it with something. It was associated with multiple endocrine neoplasia, and you could monitor it with, and let's go back to that page, that is calcitonin. So you do calcitonin levels looking for a medullary thyroid cancer, and that's one of the ways that you monitor family members of people with multiple endocrine neoplasia. Next page, we're going to talk about pheochromocytoma. At this stage, we have now filled in all of our different layers of our adrenal gland. So as part of one of the lectures, we had 3 layers of the adrenal cortex. The outermost layer made aldosterone. Interestingly, the inner 2 layers, those 2 are the ones that make androgens and cortisol. So you can see these inner 2 layers, one doesn't make one and the other makes the other. They both together make adrenal androgens and cortisol. The innermost section is the area over here where pheochromocytomas grow, in that adrenal medulla. And we have that rule of 10%. 90% of them grow in the adrenal medulla, but 10% of them, pheochromocytomas, are extra-adrenal. We had, if you had a tissue, a secretory tissue, a gland, that secreted a hormone and you had something growing in it that secreted the same hormone, that was a benign adenoma. 10% of these are malignant. So 90% of them are benign adenomas. % of people with a pheochromocytoma, it's bilateral. Treatment of these, first, in the same way that there is an order that you have to treat people with hypothyroidism. So if I have hypothyroidism, then I need to give carbimazole before I give iodine. So hypothyroid, I give carbimazole before iodine. If I have pheochromocytoma, I need to give alpha blockers before I give beta blockers. Now, why is that the case? If you imagine the adrenal gland secreting lots of adrenaline, that adrenaline stimulates alpha receptors and beta receptors. Most of the beta side of things, beta gives you two actions. One of them is vasoconstriction, but there is beta-1 mediated vasodilation. So if I move to one side, oh, it's chasing me. At the bottom here, this is beta mediated vasodilation. If I give a beta blocker first, what will end up happening is a good thing. It's lovely that the vasoconstriction has gone away, but the little bit of vasodilation that I had also goes away, and I'm only left with alpha-mediated vasoconstriction. If I give beta blockers first, blood pressure increases, so I have to give alpha blockade first because that only causes vasoconstriction. So if I take away those vasoconstriction, then my blood pressure improves, and then I can do beta blocker after that. So in pheochromocytoma, I go to give an alpha blocker before a beta blocker. If I had somebody who came in with alcoholism, and they've got a blood glucose of, I don't know, 3.1, and the question would try and lure you into, what do you give first? Do you give IV glucose for this patient's hypoglycemia and then give the patient thiamine later? And it's trying to trick you into it. No, you always, in alcoholism, without insulin, if you have a low blood glucose, you're not going to die of that. You will undergo ketosis, and that ketosis from your fat will keep your brain alive and your body going. And you must always give thiamine before you give glucose. If you give glucose first, metabolic rate goes up. Metabolic rate goes up, you don't have enough thiamine around, and you precipitate Korsakoffs. And at that stage, it's irreversible. You've damaged their brain forever. So in alcoholism, you must give thiamine before glucose. There is another one, adrenal insufficiency. Pituitary insufficiency. If my pituitary gland has died, there's only two hormones, rarely, that are vital for life. Those two hormones that are vital for life are TSH, to make thyroxine, cortisol, because cortisol is a permissive hormone. It allows all of the other hormones in your body to work. In this case, you must always give cortisol first before you give thyroxine. Because if you give thyroxine first, the metabolic rate goes up. Increased metabolic rate without any cortisol will precipitate a cardiovascular collapse. So those are which come first. These come up in exams reasonably frequently because they're things that doing it the wrong way around you can kill somebody or permanently cause brain damage. Okay. I think we can, if you've got your books on you, and you'd like to go through to take-home points. Probably one other thing when we were talking about pregnancy that I've just remembered we've got to cover. Pregnancy. In pregnancy, we talked about you pick propylthiouracil. You can use beta blockers, but ideally you would try and avoid it. You're trying to avoid beta blockers because it causes intrauterine growth retardation. If you're in an emergency and you have a thyroid crisis, you're worried about the mother dying before you're worried about the fetus dying. So at that stage, you've got to keep the mother alive, and that's by using all of the drugs that you have at your disposal. So pregnancy equals propylthiouracil. The last thing is for pregnancy is the fact that when you are pregnant, your placenta starts producing beta HCG. And we measure this as part of a pregnancy test to say whether you're pregnant or not. But also, TSH, the structure of it, looks almost identical to TSH. So we said in our Cushing's lecture, the fact that cortisol is almost identical in structure than aldosterone, so cortisol can fit in that receptor. In the same way, beta HCG can fit into the TSH receptor. So the more beta HCG you've got, the more stimulation of the TSH receptor is, and your thyroid state, your thyroxine levels go up and up and up. And those elevated thyroxine levels in early pregnancy contribute to hyperemesis, or even just emesis in pregnancy. So let's have a look at your thyroid state in pregnancy. You start off, this is your thyroid state. You become pregnant. At this stage, your thyroid state is here. That is made up of an amount of free thyroxine, which is, it's only free hormones that are metabolically active. So your free thyroxine, and then some bound thyroxine, bound to thyroid binding globulin. So this is bound to TBG. So as that's bound up, that can't have any metabolic activity in the body. The free thyroxine here at the top is the bit that's metabolically active. You become pregnant and start secreting beta HCG. Your body thinks that you are releasing TSH to stimulate the thyroid. At this stage, your body starts to upregulate the amount of thyroxine production. So you get some more free thyroxine, some more free thyroxine, some more free thyroxine. And you are becoming, the amount of thyroid binding globulin you've got around in the body is about the same. So you can see the amount of metabolically active thyroxine that is free in the circulation and not bound is going up and up. You become clinically, move from being euthyroid to clinically thyrotoxic. At this point, your body knows that something is wrong. It knows that you're pregnant, and what it does is it starts increasing the amount of thyroid binding globulin that there is to mop up your free thyroxine. So even though the total amount of thyroxine carries on increasing, you can see that the amount of free thyroxine starts to drop. And then towards the end of pregnancy, you are back down to the same amount of free thyroxine than you had at the beginning of pregnancy. So pregnancy causes hyperthyroid state, giving symptomatic hyperthyroidism, which is called thyrotoxicosis, before the body then catches up and gives an increased production of thyroid binding globulin, returning you to your euthyroid state in the last trimester of pregnancy. So our take-home points was, only Graves' disease gives you thyroid acropathy, pretibial myxedema on your legs, and exophthalmos. Again, in Graves' disease, that can be euthyroid, hyperthyroid, or hypothyroid. It was the ding-dong, ding-dong, ding-dong. Propylthiouracil is used for hyperthyroidism in pregnancy above all other anti-thyroid regimes. HCG in pregnancy can stimulate TSH receptors, causing a transient hyperthyroid state. So it's only hyperthyroid for that period of time that it takes before all of this free thyroxine is mopped up by the thyroid binding globulin. MEN1 results in parathyroid adenomas, whereas MEN2A causes parathyroid hyperplasia. Pheochromocytoma, you have the rule of tens, and we talked about 10% extraadrenal, 10% malignant, 10% bilateral. Pheochromocytoma secrete urinary catecholamines, secrete catecholamines, so we can measure metanephrines, or urinary catecholamines? Metanephrine is the better test. Papillary thyroid cancer is the most common neoplasm of the thyroid, as it is diagnosed via fine needle aspiration. Thyroid cancer of virtually any type never causes hyperthyroidism. Okay, that's the end of hyperthyroidism. We had a question. Let's just run through that very quickly as well. So you're on a GP placement, you're part of a medical rotation, you see a patient from Eastern Europe. The English-speaking relative explains that since her last visit from Armenia, the patient's appearance has changed. On examination, you note exophthalmos, clubbing, pretibial myxedema, and a moderate goiter. Her pulse is 98 and irregular, and she's dressed in summer clothes despite being cold outside. On further questioning, you also discover that she is 3 months pregnant. So we've got all of the different components all thrown in together. Take-home points. The question is, block and replace therapy usually has fewer side effects than titration of anti-thyroid medication. So this allows me to make the final point before we move on, which is there are 2 ways that we can give propylthiouracil and carbimazole. The first way is we can give a dose of it and then monitor what the response is. If the patient is still hyperthyroid, we can give an increasing dose and then monitor. Eventually get to the stage where we are at the right dose and we carry on giving the right dose, and after a long enough period of time we can actually end up stopping the medication. And people then maintain a euthyroid state. The next way is by giving a massive dose of propylthiouracil or carbimazole. The thyroid gland goes to sleep and just doesn't function anymore. And we give thyroxine to replace the fact that we've knocked off their thyroid gland. So this is called titrate. This is called block and replace. You can never do it. This is contraindicated in pregnancy because you end up knocking off the thyroid of the child that's developing. Then the symptoms, this ends up controlling it in a very physiological way. And people tolerate that very well, whereas this, lots and lots of symptoms. So block and replace therapy doesn't have fewer side effects and it's contraindicated in pregnancy. Her condition could be due to a toxic multinodular goiter. Toxic multinodular goiter wouldn't give you thyroid acropathia, pretibial myxedema. All of those are features of Graves' disease. Symptoms like these could be secondary to high levels of HCG stimulating the TSH receptor, combined with pregnancy-associated rise in TBG. Well, no, once you have a rise in TBG, that mops up all of that free TSH. So that question is yes, you could get at least the symptoms of hyperthyroidism from beta HCG. You couldn't get features of exophthalmos, pretibial, and thyroid acropathia. But eventually, by the time you had thyroid binding globulin increase, then that would make all of these symptoms go away. This patient is suffering from a thyroid storm and should be admitted to hospital. Head, she isn't having seizures. Heart, there are no features there of heart failure. Hot, she doesn't have a temperature greater than 38 degrees Celsius. Propylthiouracil is a drug of choice in this situation. There's a nice easy one there at the end. Okay, so that is the end of hypothyroidism. If anybody has any questions for that, if you can pop it in the chat. It takes a little while for it to appear in the chat, but when it does, then I'll answer it. Just very, very quickly, going to cover 1 or 2 points from inflammatory bowel disease. This is the kind of core points that allow you to score the most amount of points with the least amount of having to listen to inflammatory bowel disease, again, because it's appalling to have to listen to inflammatory bowel disease. You've heard it about 50 million times when you're at medical school, and then you've read about it to the point where you stop paying attention to it. So IBD, inflammatory bowel disease, this is the combination of Crohn's disease and ulcerative colitis. The bits that I'd like you to take of Crohn's disease or ulcerative colitis are the following. I'd like you to remember this picture. So we drew a picture of the side of a head, and we talked about paraneoplastic phenomena, and we circled small cell lung cancers, which was Lambert-Eaton myasthenic syndrome, ectopic ACTH, ectopic ADH secretion. Then we talked about the non-small cell lung cancers. These were the ones at the back. Those were cerebellar, Hugh, Yo, and Rhee, parathyroid hormone-related peptide, ectopic TSH secretion. And in the same type of way, this diagram is an aide-memoire to help you remember the differentiating of which occurs more commonly in one condition than another. So that's the liver, that's the biliary tree, and this is the bowel. And in a different colour, I am going to put the gallbladder here. I don't know why I'm putting it on that side, maybe I'll put it on the other side. Let's put the gallbladder over here. So, anything that you see in red equals more common in ulcerative colitis than it is in Crohn's. Then we have blue, things that you can see in blue, and everything else is more common in Crohn's than ulcerative colitis. So we played a game where we went through hematological malignancies and we said which of them causes lymphadenopathy, and we gave you a trick and we said lymphoma, myeloma, chronic lymphocytic leukemia, etc., and you were able to pick it out. The same goes true when you're looking. If I said which in inflammatory bowel disease is autoimmune hepatitis more common in ulcerative colitis than in Crohn's, well, you remember back to this picture and you say, I remember liver autoimmune hepatitis is more common in ulcerative colitis because it's in red. Primary sclerosing cholangitis, that's this biliary tree, it's more common in ulcerative colitis. Primary biliary cirrhosis, more common in ulcerative colitis than it is in Crohn's disease. What about gallstones? Well, the gallbladder over here, gallbladder is in blue, so that is more common in Crohn's than ulcerative colitis. What about pyoderma gangrenosum? Well, it's not in red over here. So pyoderma gangrenosum is more common in Crohn's than ulcerative colitis. What about enteropathic arthritis? That's when you've got pathology of your enteric system, your gastrointestinal system. If you had enteropathic arthritis, it's not in red, so it's more common in Crohn's disease. What about anterior uveitis? In Crohn's disease and ulcerative colitis. Toxic